Hello and good afternoon. I'm Dr. Eric Rashba. Thank you for joining us today as we observe Heart Month. I am director of the Heart Rhythm Center at Stony Brook University Heart Institute, and I'm joined today by Dr. Roger Fan and Dr. Abhijeet Singh. Dr. Fan joined us way back in 2008. His expertise is in ablation, particularly complex ablation of all kinds of arrhythmias. And Dr. Singh joined us a few years ago. He trained at an excellent institution, the Stony Brook Heart Institute. And after a few years in clinical practice, has come home to join us here at Stony Brook. So we're very pleased to have him as well. The Stony Brook Heart Rhythm Center includes a team of board-certified cardiac electrophysiologists who specialize in heart rhythm disorders. During today's session, there is a comment box where you can submit questions, and we will try to respond to them as they come up. Dr. Singh?
Hello, everyone. Welcome. I'm happy to be with you today. Heart Month is an opportunity for us to learn more about heart health. And it's also a reminder for us to take action to ensure that we stay healthy. And today's topic is atrial fibrillation.
And the reason why atrial fibrillation is so important is because it's such a large problem. It's the most common heart rhythm disorder, what we call arrhythmia, in the world. In the United States alone, 75,000 Americans will have a new diagnosis of Afib every single year. In fact, 1 out of 4 US adults will have Afib at some point during their lifetime.
Great, thank you. So why don't we start by just talking about the normal electrical activity of the heart when someone does not have atrial fibrillation. So with each heartbeat, the heart has an electrical system. So each heartbeat starts in the right upper chamber of the heart, and the sinus node travels down the electrical cabling of the heart through the center to the bottom in a very coordinated way. This way, the upper chambers of the heart contract when they need to, fill the lower chambers, which then distribute blood to the rest of the body. Dr. Fan, can you tell us kind of what happens when patients have atrial fibrillation and how that differs from the normal situation?
Yeah, in atrial fibrillation, that nice coordinated, very precise activity of the upper chamber of the heart, that degenerates. So normally the upper chamber of the heart beats around 60, 80 beats per minute. In AFib, that becomes disorganized and chaotic, can beat up to 400 beats per minute. So instead of a nice forceful contraction of the heart, it essentially turns into more of a quiver, and it becomes a very inefficient pumping of the heart. In addition, that rapidity of the top chamber of the heart can get transmitted to the bottom chambers. So the entire heart can beat very erratically, very quickly, very inefficiently.
That's great. Can you comment a little more on what the consequences of that are? Like what kind of symptoms a patient may have, you know, how that may affect them, how they would know it?
Yeah, so because of that inefficient contraction of that top chamber of the heart, the blood doesn't flow as well. So the blood can have what we call stasis, and the blood can clot. And these clots, if they dislodge and travel to the brain, they could cause stroke. That's the main problem that we worry about AFib, the stroke risk. In addition, there can be other problems. If the heart beats very quickly, irregularly, patients can feel symptoms. Symptoms can range from palpitations to chest discomfort and shortness of breath. But lastly, the AFib can also lead to very rapid heart rate, and over time that can weaken the heart muscle and lead to what we call heart failure or cardiomyopathies.
Yes, and that's increasingly appreciated how patients with heart failure who have fluid overload, shortness of breath, can't do their normal activity, how that may be influenced by atrial fibrillation and how it can be improved by treating it effectively. Dr. Singh, can you share some of the causes and risk factors of atrial fibrillation?
Thank you, Dr. Rashba. That's a very important thing that comes up on a daily basis. AFib being so common, There are risk factors that can be divided into modifiable and non-modifiable risk factors. So non-modifiable risk factors, things that we cannot do anything about, are age, just getting old. Being above 60 or 65 years of age increases your chances of developing atrial fibrillation. Non-modifiable risk factors also include a family history. If you have like a first-degree family member who has atrial fibrillation, your chances of atrial fibrillation go up. Also being of European descent. Patients with European descent have a higher tendency of developing atrial fibrillation in their lifetime. And then coming to the modifiable risk factors, things that we can do something about to reduce the risk of AFib. And that includes high blood pressure. If you treat high blood pressure, that can reduce your incidence of having atrial fibrillation. Maintaining a healthy weight. If your body mass index is more than 27, that's been associated with an increased risk of developing atrial fibrillation. Treating sleep apnea. So we have a lot of patients and a lot of research which says that if you have sleep apnea and you treat it, your risk of atrial fibrillation goes down to someone who does not have atrial fibrillation. So that's another risk factor that's modifiable. And then controlling diabetes, reducing the amount of alcohol that you take. For the most part, it's less than 7 drinks a week. Limiting your smoking and basically controlling your cholesterol levels. So these are some of the risk factors for atrial fibrillation.
Yeah, agreed. I would say some of the most important ones are alcohol. Probably you don't want to have all those 7 drinks at once, right?
Yeah, better to space them out.
Or better yet, maybe have less of them. So that's a common thing that I'm always surprised that patients aren't aware of. When we get consulted on patients, there's often no alcohol history on the chart, but when we ask them, all of a sudden we find out they drink a lot of alcohol. Fairly common in patients with AFib, and it's definitely something that they can fix. It's one of the major causes. Caffeine somewhat, but maybe less of a tight link. But, a lot of the excitement in recent years has been about, like you said, modifiable risk factors, particularly weight, exercise, and sleep apnea, like you mentioned. So treating sleep apnea is very important. But there's actual clinical trial data showing that if you lose some weight and also if you exercise, the two are independent, meaning they both matter. If you get some aerobic exercise and lose weight, that actually reduces what we call the AFib burden, so the total amount of AFib that you might have. So, patients often ask, what can I do to fix this? No one's or not no one, but people aren't always enthusiastic about taking drugs, having procedures. That's they want to hear what they can do to fix things first. So I would say avoiding alcohol, losing weight, aerobic exercise is what I tell them. So Dr. Fan, can you tell us a little more about the Afib symptoms? You touched on that a little bit earlier, but things to be aware of and things that patients may not be aware of.
Yeah, this is a good question because this is something that a lot of patients can be confused by, because everybody knows patients with AFib, and the symptoms from AFib vary very widely between patient by patient. So on one end of the spectrum, patient have almost no symptoms in AFib. On the other end of the spectrum, patients can be extraordinarily symptomatic. So the main symptomatic findings are, number one, palpitations, a sensation of fluttering or unevenness in the chest. Other symptoms can be chest discomfort, chest tightness, trouble breathing. Sometimes it can even lead to sensation of dizziness or feeling want to pass out. Then when you move to the more moderate end of the spectrum of symptoms can be a little more subtle. It could be a sensation of fatigue, lack of energy. Even though these symptoms are subtle, they really can affect your quality of life. And then towards the more mild end of the spectrum, patients can have very infrequent symptoms or even no symptoms at all. But what you have to understand is, or patients have to understand is, there's a disconnect between symptoms and prognosis and risk. There's not really a direct correlation between the two. So if you're lucky enough to have no symptoms in AFib, it doesn't mean you're really out of the woods, because you still can have risk for stroke. You can have risk for fast heart rates and developing cardiomyopathies or heart failure. So you still need to pay attention to these findings and be treated adequately if you need to. Then on the flip end of the spectrum, if you're unlucky and you have a lot of symptoms with your AFib, debilitating symptoms, that doesn't necessarily mean your AFib is more dangerous than somebody who doesn't have symptoms. So every patient is very different in the way they manifest their AFib symptoms.
Dr. Singh, can you talk a little bit about, how we figure out how patients have AFib to begin with? I mean, sometimes it's evident, they'll come into the ER, we'll do an EKG and they're in AFib, but as Dr. Fan was kind of just saying, a lot of times people have palpitations, what can patients expect when we haven't yet documented AFib, how we might go about trying to, make the diagnosis so we know how to treat them properly?
Yeah, that's a great question. We have to be able to diagnose to give recommendations for treatment. And now over the last few years, there's been a huge jump in the technology that's available to diagnose atrial fibrillation. So obviously the gold standard is when you have symptoms, you come to the ER, we do an EKG and we diagnose you with atrial fibrillation. But now with the advent of Fitbit and Apple Watch and Cardia, there is patients can buy these equipment in their house, and these monitors them and if they have symptoms, even if they don't have symptoms, like the Apple Watch is going to give them an alert that they have an irregular heart rhythm, and they can actually record a one-lead EKG and email it to their physician. Then we also have equipment like loop recorders. These are implantable chips that we can put under the skin. The procedure takes about 5 minutes to do. We just put a small chip that goes under the skin and it can monitor your heart 24/7. And the battery life on those things is about 3.5, 4 years. So if you have palpitations, if you have some symptoms, but we've never actually documented a heart rhythm problem, I think there's a lot of technology out there that we can use to make a confirmatory diagnosis.
Yeah, it's kind of the new world now where we're getting patients emailing us little EKGs from their Apple Watch or Cardia device, which is a little device that can record an EKG on your cell phone also. And they can be pretty helpful. The other thing for patients to be aware of, everyone thinks of like external monitors as like this 2-pound device that you have to clip to your belt and with 20 wires that you're hooked up to. They have improved a lot in recent years. It's now like a patch. All the manufacturers have, a water-resistant patch that you just put on the chest, and you're able to take a shower. You can't like soak yourself in a jacuzzi, but yes, you can take a shower, and the device will still do everything that it needs to do, and it's a little more comfortable for patients. Yeah, the diagnostics are very important. The other thing I would add is sometimes, people have palpitations, we try to figure that out, but we're called on very frequently now to investigate causes of stroke, and people who, they're admitted with stroke, the neurologist can't figure out why they have it. There's no arrhythmia observed while they're in the hospital. So we do a lot of monitoring now, both external monitoring and the implanted loop recorders to try to detect AFib in people who have a prior stroke. And with long-term monitoring, up to 1/3 of patients will actually have AFib that we find. The reason why it's important, as we'll talk about therapeutics, is that those people need to be on the right medications to prevent another stroke, and we will talk about what that is. Dr. Fan, why should we worry about AFib? We're kind of already talking about that a bit, but can you expand just a little bit more?
Yes, just as you mentioned, stroke risk is really the thing that we worry about the most. In fact, quarter to a third of all strokes in the U.S. are attributable to AFib. So like Dr. Rashba said, when patients come to the hospital and we can't figure out what caused the stroke, in general, 1/3 of those end up being due to AFib. So it's a big problem. Treatment of that can range from blood thinners to even devices to close off the area of the heart that could cause these strokes if patients can't tolerate blood thinners. So we do have good therapies for this and preventions for this. The other issues we talked about, problems that AFib can cause, number one is symptoms. Now, some patients have really pretty debilitating symptoms in AFib, and we have a lot of range of options from treating this, from simple medicines to controlling the heart rate to more complicated medicines to suppress the AFib, to even procedures to fix it. And our decision to pursue these therapies depends on how much the AFib bothers you, how much it's debilitating. And that kind of gauges how aggressive we are in treating it. And then the last part of it is, even if patients don't have any symptoms with AFib, if the heart races uncontrollably, or you're in AFib for a long period of time, that could eventually weaken the heart muscle and cause what we call a cardiomyopathy or heart failure. So we watch carefully for this. We try to prevent this. And again, the therapies are similar, medicines, antiarrhythmics, ablation. And we take all of this into account when we decide, which therapy we choose for the patient.
Yeah, the other thing I would mention also is we tend to think of, dementia, Alzheimer's as something you just get as you get older, but a substantial proportion of those are probably what we call multi-infarct dementia, possibly what we call emboli, so clots that form in the heart from AFib that a patient doesn't even know that they have and go to the brain. So if we had diagnosed that, you can actually probably prevent some of the dementia that's out there. All right, so moving on to therapeutics, Dr. Singh, tell us a little bit about medications, different classes of medications that we might use to treat AFib, both for stroke prevention and also to treat symptoms.
Yes, very important question, and that comes up on a daily basis. As far as therapeutics go, we can divide it into medications that help prevent a stroke from atrial fibrillation. And warfarin, or sometimes called rat poison, used to be the medication that was the only medication out there that people would use for atrial fibrillation. And the only indication to use warfarin at this point is if the patient has atrial fibrillation, that's because of a valvular heart disease, which means one of the valve in the heart is causing problems, and that's what's causing patients to develop atrial fibrillation, or if they have a mechanical valve. So these are the only two indications where I would put patients on warfarin. But apart from that, in the last 10 years, we've had medications that have come out there which have a lower risk of bleeding as compared to warfarin, and they have a lower risk of stroke, and they don't need their blood levels to be checked. So with warfarin, the problem is, as you know, the blood levels needs to be checked once a week to once a month, and the warfarin interacts with the food, interacts with the amount of warfarin and everything else. With these newer blood thinners, they don't interact with the food that you eat, and you just take a pill and your blood is as thin as it needs to be. So I think that's become a game changer in reducing the risk of stroke in people who have atrial fibrillation. And the other aspect is medications that we can use to control atrial fibrillation. So sometimes if you don't have any symptoms from atrial fibrillation and your heart rate is controlled, we can just put you on some medications to control the heart rate when you exercise or something else, so it doesn't reduce your heart muscle function. So as long as we can do that and you don't have any symptoms, you can just continue on those medications. And then there's a different tier of medications called anti-arrhythmic medications. These medications basically prevent you from going into atrial fibrillation. Now, none of these medications is 100% effective. The most effective medication out there is about 70% effective at the end of 1 year. But that medication has a ton of side effects. You need to monitor patients for problems with the liver, lungs, thyroid, skin, eyes. And there are other medications that are not as effective, maybe 20–30% effective, but they also don't have the side effects. So there are a lot of medications that are out there that can help control the symptoms of AFib and prevent people from going into AFib, but they need to be monitored. And then apart from medications to prevent a stroke from atrial fibrillation, there are also some procedures that can be done. And I'll let you elaborate more on those.
Great. Just to elaborate briefly in terms of Coumadin, I mean, one thing we still deal with fairly frequently, especially in our Medicare age population, we all probably agree that the new anticoagulants are, easier to take, better, but There are still financial issues, particularly in the Medicare population, where they can't use these coupons that the manufacturers provide. So, I mean, some patients have to take Coumadin. It says Coumadin on the bottle, it doesn't say rat poison. So if that's your best option, it's still better than not taking anything. We'll talk a little bit about other options, you know, and some of the manufacturers of the newer drugs do have patient assistance programs, even for Medicare age population. But those new anticoagulants are definitely a major advance. So you gave us a nice lead into other treatments. So Dr. Fenn, how would we decide on picking, you know, other treatments for AFib, and, you know, medications first or not, or how do we go about choosing?
Thanks. Yeah, you know, like Dr. Singh said, there's a lot of good medication options for AFib, but some patients, the medicines don't work out, or they don't really want to be on the medicines. In that case, we have potentially curative procedure for AFib called the Catheter Ablation. That's a minimally invasive procedure where in a good amount of patients, we're able to fix their AFib. So the way we do this is we weave tiny catheters or tiny wires through both sides of the groin, through the veins, up into the heart. And we isolate the areas that cause the AFib by using heat energy to cauterize those regions. So depending on how much AFib you've had at that point, we can have pretty good success rates treating AFib. So if patients are caught early, their AFib lasts only for minutes or hours, and they don't have that much of it, our cure rates are up to 85 to 90% for one procedure. But if people have AFib that's caught later in the course, or it's lasting longer, you know, days to weeks at an end, then our cure rates may not be as good because the heart becomes locked in AFib. So the cure rates go down to maybe 60 to 70%. So that emphasizes one of the important things that we like to emphasize to other clinicians and patients, is that we have to catch AFib early in the course if we want to fix it, because our outcomes are better that way. But some patients always ask, well, you know, I know patients or people who've come back for more than one ablation. Why is that? Well, you know, like we said, our cure rates are pretty good, but they're not perfect. You know, 85 to 90% in patients with, you know, paroxysmal or self-limited AFib. So that means 10 to 15% of patients, they may have recurrent AFib afterwards. But we're still able to treat that. We can do the same procedure again, touch up areas that may have been completely ablated the first time around, or they might have AFib coming from atypical spots, and we can look for these spots and treat that as well. So the ablation option is a very good option for treating AFib. Really, it's the cornerstone of our profession. But, you know, there's a lot of decision making that comes into whether or not a patient needs an ablation, you know, based on how aggressive they want to be, how bad their symptoms are. And so the take-home message of the therapies is there's a lot of good therapies out there. We tailor it to, you know, the patient's you know, individual situation.
Great. So I guess I would add, just in comparison to drugs in the clinical trials, you know, ablation is twice as effective. That's why it's kind of moved up in terms of, you know, guideline recommendations. The other thing you kind of touched on is, you know, definitely intervening earlier in the course makes a difference. Part of that relates to the degree of structural disease. So as people are in AFib longer, there's actually what we call structural remodeling, meaning the atrium, the top chamber, the left upper chamber where the AFib comes from, can actually dilate over time. And the bigger that chamber is, the more able it is to sustain AFib. So often these are the things we look at to decide on, you know, whether a patient should get an ablation, how successful it's likely to be. The other things we look at are, you know, typically findings on an echocardiogram, you know, if they have leaky valves, particularly the mitral valve. Sometimes if it's severely leaky, that's more of a surgical problem, and the surgeon can do ablation while they're fixing the valve, actually, with open heart surgery. So agreed. Thank you for that. So can you talk a little more about stroke risk? You kind of touched on that a bit, but how we go about figuring out who's at risk for stroke, and deciding who needs a blood thinner.
Yeah, so the risk of stroke in general in people who have atrial fibrillation is 5 times the general population. And over the years, we've come up with these risk scores that we use to stratify patients if they need to be on blood thinners or not. And the risk score doesn't take into account whether you're in atrial fibrillation once in a while or you're in atrial fibrillation all the time. Your risk of stroke, we consider till now, is pretty much the same. So, and the risk factors that would put you at a higher risk of having a stroke would include being above 65, especially above 75 years of age, having high blood pressure, having diabetes, having had a history of stroke, having congestive heart failure. So these are some of the risk factors that increase your chances of having a stroke. So whenever we see a patient who has atrial fibrillation, we have to decide if the risk of bleeding is going to outweigh the benefit or it's the other way around. So the risk scoring that we use is called CHADS-VASc scoring that your clinician will use to decide if you need to be on blood thinners or not. And then the scenario comes up in which you are at risk of having a stroke, but you just don't tolerate blood thinners. Either it's because of bleeding issues or because the levels are not where they need to be. And in that case, we have therapeutic options. We have this device which we can go in through the groin and place in the heart that prevents the clots from dislodging from the heart and causing a stroke. And I'll reference to you, Dr. Rashba, about further details about this device.
Right. So what Dr. Singh is talking about is left atrial appendage closure. So we know that 90% of the clots that happen in AFib form in an area called the appendage. It's a little sac, kind of a blind alley that is attached to the left upper chamber of the heart. Blood flow is a lot less in that area, so that's why the clots tend to form there. So there are devices that we can insert through the groin up to the heart. It's like an umbrella-like device that seals off that appendage so that clots that may form cannot get out to the rest of the heart and go to the brain. So you still need to be on a blood thinner for 6 weeks after we put it in while the device heals in the body. After that, you take 2 medications that are typically given after people have a stent, aspirin and clopidogrel or Plavix for 6 months, and then just long-term aspirin. So in the studies that have looked at this, the clinically approved device is called Watchman. You know, the ability to prevent strokes is similar to a blood thinner, but the risk of bleeding is a lot less. So we tend to look at this for patients who fall, injure themselves, or have had prior bleeding episodes, particularly GI bleeding. And a lot of times patients just, have, less serious bleeding, but just bothersome bleeding episodes that brings them to question whether they still want to be on a blood thinner. Even in clinical trials, about 25% of patients stop blood thinners, even when they have a clinical trial nurse calling them and asking them if they're taking their pills. So it's an important option for many patients. So Dr. Fan had kind of commented on procedures for AFib. Just a word about our facilities and what we have available at Stony Brook. So currently we have 2 electrophysiology laboratories. We have all the equipment we need to do all the procedures for atrial fibrillation. There are different kinds of ablation for AFib. We can do radiofrequency where we heat the heart tissue, as well as cryoablation where we freeze it. There are reasons why electrophysiologists choose one or the other. In clinical studies, they work about the same, but we have both technologies as well as what we call mapping systems. It's like a 3D GPS that helps us figure out where we are in the heart and actually minimize or eliminate the use of X-ray, which is very important for patients and staff. So we have two electrophysiology laboratories now, and we're in the process of building a third, which in March is going to go live. So we've been doing so many of these ablation procedures. It's such a growth area. So many people have AFib that we need more capacity to accommodate it. So this is going to be a beautiful new state-of-the-art lab that will allow us to kind of expand our services to our community. And our two existing labs will be upgraded to the same standard. So right now we're able to do everything we need to do, but it'll be even nicer. It's time to upgrade after they've reached their service life. So we're very happy about that, and that we have that to offer to our community right here in the Stony Brook area. Dr. Fan, what do people need to know to ensure that they're receiving the best heart rhythm care?
Thanks. That's a pretty tough question, pretty all-encompassing, but I think the most important thing patients should focus on is that their physician individualizes the care just for them. Because, over the course of this, program, you've seen that AFib is very complex. Symptoms can have very varied symptom manifestations. They have different risks for stroke, for heart failure. But very importantly, patients have very different preferences in how they want to be treated, how aggressive they want to be treated. For example, there are some patients who say, well, I want to try to minimize medicines in the long run. I don't want to take a lot of medicines. So I'd rather nip it in the bud, do a procedure to try to fix it, to minimize the amount of medicines I need to be on down the road. But then we have other patients who say, well, my whole goal is to minimize the need for me to undergo a procedure, and I'd rather be on meds. I don't mind being on that. So it's important for your physician to take into account all of these aspects of care and find a strategy that is safe and effective and works for you. And so I think that's the most important part of the care, that you feel comfortable with your doc, that they're looking through all of these aspects and then finding a good solution tailored for you.
I think that's very important. We always kind of joke about how, when you get sent to a surgeon, you're going to get an operation, but, we tend not to practice that way. As you said, it's you want to see someone who's going to listen to you, find out what's important to you, and make the best decision that takes into account your preferences. So also letting what's out there in terms of treatment and why we might recommend it, so you clearly understand what's going on. All right, well, I think that just about does it. Thank you for joining us for this program. Hope you use this month to educate yourself more about your heart health and electrical disorders of the heart. Thank you very much.